All right, well, let's go ahead and get started. For those of you who don't know me, I am Arden Schwenker. I am one of the partners of Grow Midwives, and I'm also run our billing service, GM Billing. In addition, I am a certified compliance officer and a certified OB coder. I have been billing and coding for midwifery services, maternity care, and family practice for almost 20 years. And the presentation that we're doing tonight, that we will put on our YouTube channel, is what I did at the ACNM conference. But I also thought that we needed a more current billing and coding webinar up on our YouTube channel and our website. And there will be plenty of time at the end for questions. And if I start going too fast, somebody tell me to slow down because I forget that not everyone knows this as well as I do. So, with that being said, tonight we're going to talk about the practical steps for midwifery billing and coding. And the objectives are I'm going to go through some different billing and coding examples that I received from practices that I bill for or consulting clients with questions. So these are all real-time scenarios. We're going to talk about some key compliance factors that are important for everyone to know, and then just do a review of the incident to billing guidelines because that always comes up in questions. So let's start with some billing scenarios or different questions. The first one is a patient comes into the office for a well woman visit. While there, additional problems are discussed. Are the additional problems billable? My favorite answer is it depends. But you can bill for a well woman exam and a problem visit together, but only if the problem requires a significant, separately identifiable, and medically necessary E&M service beyond the scope of the routine preventive visit. So, for example, someone comes in for a well woman exam and you manage hypertension or you discuss abnormal bleeding, or they present with a new problem that you haven't talked to them about before and it's not notated anywhere else in their chart. That signifies a separate, identifiable, and medically necessary service, so you can bill that in addition to the well woman exam. So a common question then is, how do I bill that? So they have to be, again, two significant, separately identifiable services. You have to separate the documentation for both services. So you document the well woman exam, and then you, in addition, document, I spent an additional 20 minutes face to face with the patient addressing and detail the problems that you addressed. Your biller will put a modifier 25 on the E&M code. So, for example, you would bill that well woman exam with a 99385 and 99213 with modifier 25. Now, payer policies vary. Some payers will not pay the second code, they won't pay the E&M code. Some payers will require the 25 modifier on the well woman exam, but that's for your biller to know, not necessarily you as the provider, but your biller should be aware of each of the different payer policies. And then the other thing to be aware of is that the patient will be, they will receive or potentially receive a copay or co-insurance on the E&M service. That will not be covered at 100%. And that is where most of the patient questions will come from, is the additional copay or co-insurance that they will have. So, what does not qualify to be billed together? So, minor issues, things you've already that have already been addressed in a previous visit that are not significant, or things that are being treated by their primary care physician. Trivial or insignificant problems, just something they mention in passing that you don't really discuss with them or you're not managing or treating, or any routine medication refills. They come in for a well woman exam and you refill their blood pressure medicine, but you don't really discuss hypertension. That is not separately billable. Second scenario, a patient comes in for their well woman visit and you insert an IUD. How is this billed? So this has two separate caveats. Was the IUD discussed and ordered at a previous visit and you knew you were inserting it during this visit? Or did you do contraceptive management with the patient and discuss various forms of birth control and an IUD was decided during this particular visit? If the IUD was discussed and ordered during a previous visit, then you can bill the well woman exam and the IUD insertion with just those two codes, the 9938 code for the well or 39 code for the well woman exam with a modifier 25, and then the CPT code for the IUD insertion. And then in addition to that, your biller or will want to add the code for the IUD. If you did contraceptive counseling during the visit, the patient didn't know, um, the patient did not know that they were going to, they, they had not previously chosen an IUD insertion, then you can bill the well woman exam, the E&M code for contraceptive management and initial prescription of an IUD. And in addition, you can bill for the IUD insertion.
So,
So
Arden,
that's where it becomes more complex, and you have to stop and think about, did they come in wanting an IUD and knowing it was going to be inserted during this visit? Or was it something that you was not previously decided and during this visit you decided to do the IUD?
Arden, do
Yes.
you want questions as they pop up related to the slide, or do you want them to wait?
Um, we can do them as they pop up because we might not remember them in the end.
Okay, so this may go back to the last one, but the question is, are you allowed to do a G2211 add-on for an annual exam patient that you see year after year, in addition to a modifier 25, if you are addressing extra things outside of the annual, such as vaginitis, menopause, pelvic pain?
So the G codes are only applicable to Medicare. And you cannot bill a preventive code such as 99385 or 99395 to Medicare. So if you are addressing an extra thing outside of the annual, such as vaginitis, menopause, pelvic pain, etc., if it is a significant issue, you can bill it with an E&M code.
Amber says thank you.
You're welcome.
Here's another one. I was always under the impression that discussing and prescribing contraception was part of the annual. Is this separate E&M?
So it really depends on the payer policy. Um, but according to ACOG guidelines, it is a separately billable charge. So discussing and prescribing new contraception. So if it's the initial prescription of a new contraception, IUD, Nexplanon, diaphragm, birth control, whatever the case may be, that is billable. If it's refilling a prescription, then it's not separately billable. So when you are billing these exams and you have more than one thing happening, well woman exam, contraceptive counseling, IUD insertion, all of those things need to be charted separately. They don't have to be a separate chart. They just have to be charted separately within that encounter. And then you also need to chart the total time spent on the contraceptive counseling in addition to the time that was spent on the well woman exam. So, for example, your chart would need to say, I spent an additional 15 minutes face to face with the patient discussing various forms of contraception. And then on the IUD, or if you're doing an Explanon or whatever it is that you are doing, you need to make sure you chart the device, the lot number, the expiration date, and if you have it, the NDC code. Now, those of you in larger healthcare systems, you're scanning a barcode, it's all going into Epic or Cerner. In smaller practices, you have to actually type that out into your chart note. And then the other thing in the chart is you'll want to chart if the device was stock or if it was obtained from specialty pharmacy, because your biller will bill it differently depending upon where you receive the device. Next scenario, a patient comes in for a routine postpartum visit and they decide they want an Nexplanon. Do you have them return for another visit or do you do the procedure? So the postpartum visit is included in global. If you were, oh, sorry, I just saw a question pop up, so I'll answer that real quick. Um, not, it's in a separate section within the same encounter note, not a separate note. And if there's an abnormal finding on a well woman exam, you that is not billed separately. So the well woman exam codes now they have two codes. Well woman exam with abnormal findings or well woman exam without abnormal findings. They don't pay any differently. They pay the same amount of money, but it's two separate codes and the abnormal findings are not billed separately as a problem visit, but they do oftentimes allow you to do a follow-up visit to address those findings at another visit. Okay. I think I got ahead of my slides, so I'm going to go back. Well, it's taking me forward instead of backwards. One second. Okay. So let's go back to patient comes in for a postpartum visit and they want an Explanon. How do you handle that? So if you were the delivering practice and the postpartum visit is included in global, that visit is not billable. However, the Nexplanon is. So some payers will require that the postpartum visit is still on the claim. I'm not sure why, because it has nothing to do with the Nexplanon, but some payers require it. But what's most important is that you document the initial prescription of the Nexplanon and then the code for the insertion and the device. And then they must be charted separately. So the postpartum visit, they can, again, they can all be in the same encounter, but it's a separate section within that note. So the postpartum visit and then the Nexplanon insertion. And you'll want to make sure that you're charting the total time spent on the postpartum visit and then the device lot number and expiration date. And then again, chart if the device was stock or obtained from specialty pharmacy. And postpartum visits only go until 6 weeks, according to all insurance companies. Even if you are in a state where postpartum, there's expansion for postpartum for up to 1 year, postpartum visits included in the global period are only until 6 weeks postpartum. This one I get questions on from almost every single client that I do any consulting or training on billing. Is a confirmation of pregnancy visit billable? So, a confirmation of pregnancy visit is separately billable outside of the global period if you have not started the OB record, meaning the prenatal flow sheet has not been started, health and history has not been started, none of that. A confirmation of pregnancy visit has to be charted in order for it to be billable. It has to be charted as an exam and an encounter for a pregnancy test, and then the result positive or the result negative. If the result is positive on a UPT, you can also do an ultrasound and include that in the confirmation of pregnancy visit. And I'll go back to the questions on postpartum in a second. So for this, you chart that the patient is there to confirm pregnancy, the date of the last menstrual period, and the result of the urine pregnancy test. If the ultrasound is done, you chart that also because that's separately billable or it's billable in this visit and the total time spent on the confirmation visit. And again, you cannot start the prenatal record or the visit is included in global. And that's where most people get confused. A prenatal one is included in global, a confirmation of pregnancy visit is not. Um, so back to postpartum. If someone comes in at 7 weeks, we bill it as a problem visit. Yes, 7 weeks postpartum is no longer included in the global period. It is now a problem visit. Same at 8 weeks, 9 weeks, 10 weeks. It's all separately billable, not part of the global period. So if you're told you can't do ultrasounds at their confirmation visit, that is um your biller needing additional education on what you can do in the confirmation of pregnancy visit. You can call it amenorrhea, you can call it confirmation of pregnancy. It's the same thing. You just cannot code it as a prenatal visit. So you cannot use number of weeks pregnancy. You cannot use that it's an encounter for a routine prenatal visit. The patient is there simply to confirm pregnancy. And you can do HCG instead of a urine pregnancy test. That part doesn't matter. What matters is how it's charted. It has to be charted as an exam and not as in the prenatal flow sheet. If a patient comes in with an ultrasound from an outside source to establish care, then you're starting the prenatal record. It's no longer a confirmation of pregnancy because you already know they're pregnant. And also confirmation of pregnancy visits cannot be billed after 12 weeks. They can only be billed up to 12 weeks gestation. Any other questions on this one before we move on to the next one?
Arden, I'm just sitting here innocently. This is Ginger, so I'll undisguise myself. This could be a fair amount of money we're talking about here. Confirmation of pregnancy.
So the visit itself pays, depending on what state you're in and how you code it. Most confirmation of pregnancy, you're not spending a lot of time with the patient. The majority of the time is spent on an ultrasound, because you are then moving or scheduling their prenatal one for another day. But so the visit itself is not really where you're going to get a lot of additional revenue, though any additional revenue helps. The ultrasound is where you're going to get the additional revenue.
So someone earlier said that they're not allowed to do ultrasounds at the confirmation visit, and your response is that's not true. They need to find out who's telling them that. It could be the biller, it could be policy.
It could be policy. It very well could be policy. It could depend too on the type of practice that you're in. And are you in a larger institutional practice where you're not billing for ultrasounds at all? Or are you in a practice where, or are you in a state such as Georgia, Blue Cross Blue Shield, for example, includes three ultrasounds in global. They don't pay them outside of global. So it really depends on the state you're in, but best practice is chart it, code it, bill it. And if your billers aren't billing it, find out why. The usual reimbursement for a confirmation ultrasound really depends on what state you're in. I've seen it reimburse as low as $60 and as high as 300. It just depends on the state and your contract with the payer. Also, your payer mix. If you're seeing more Medicaid, it's going to reimburse a lot lower. Another question that comes up a lot is when can I bill for an OB triage visit? So, if the patient's admitted for inpatient or observation care, then the triage is often rolled into the admission charge. Some hospitals have an OB triage area that's classified as an emergency department, and in that instance, it's billed as an emergency or emergency triage visit, but you use the ED codes instead of the triage codes. In either one of those scenarios, if the patient is admitted as inpatient within 24 hours of the triage visit, it's not separately billable. So if they're not admitted and they're outpatient triage, it's an E&M code. If they meet the criteria for observation, then it's the observation codes. Global OB. There's also confusion, more so with billers, I think, than providers around billing global maternity care. So the AMA defines global maternity as the total OB package that includes antepartum care, delivery, and postpartum care when the same group or other physician or other healthcare professionals all provide components of the OB package. The key there is the same group. When it's all in the same group, it's global maternity. So things that are included in global, now ACOG defines what is and isn't included in global. So all routine prenatal visits are included in global maternity. Initial and subsequent history and physical exams, recording of weight, blood pressure, fetal heart tones, UAs, H&P, Inpatient E&M services within 24 hours of delivery, labor management, vaginal or C-section, all that's global. So is the delivery of the placenta and any routine medications such as Pitocin. If you insert a cervical dilator within 24 hours of delivery, global. If you repair first or second degree laceration, global. Um, Basically, anything that they determine routine is included in global. Some things not on this list that are part of global are vaginitis, mastitis. Those are all now considered global. And then any routine postpartum care provided within 6 weeks of delivery. And routine postpartum care within 6 weeks of delivery is a very vague statement because in some practices, routine postpartum care is 24-hour, 1 week, 2 week, 4 week, 6 week. In other practices, it's 1 week, 6 week. All of those are included in global. And then any education services, lactation, childbirth education, nutrition, all of that is included in global if you are the delivering practice.
So are
Um, yes,
over on the questions, there was one about how you differentiate an outpatient versus observation status.
it oftentimes that is defined by the setting that you are in. So if you're doing triage in a birth center, outpatient. If you are doing triage in a hospital but not in OB triage, it's typically outpatient. OB triage, observation.
Yeah. So there's now, I knew this was going to pop up and they're firing in now, Arden. It's all about lactation and global.
Yes. So if you are the delivering practice, lactation is included in global maternity care if billed under mom. Lactation billed under the newborn is outside of global. If you, and I know that the Affordable Care Act states that lactation is a covered service, but lactation is a covered service when it is done. Well, let me back up. Most commercial insurance plans state that lactation is a covered service when it is done in a pediatrician's office and billed under the newborn and then the mom. If the lactation visit is done by an FNP IBCLC in your practice and you are the delivering practice, it's included in global. Um, you can still bill though for feeding problems or um, weight on low weight gain, high weight gain, different problems in the newborn. There are ways you can bill it under the newborn, but you can't bill it under the mom if you're the delivering practice. To bill a confirmation visit, you have to have a documented positive or negative pregnancy test because the patient could be there to confirm pregnancy and the test could be negative, and then you can still bill the visit as long as you don't start the prenatal record. Um, so if patients seen in the office and triage in the same day, I would bill the triage visit. What's not considered part of global? The pregnancy confirmation visit, which we've talked about, any lab tests, which are typically billed by the lab, ultrasounds, NSTs, all of those are not part of global. Insertion of a dilator more than 24 hours before delivery, which I understand is not common. Um, any E&M services for management of conditions unrelated to pregnancy. So someone's there for a routine prenatal visit and they have bronchitis and you prescribe medication for it, not related to pregnancy, separately billable. Additional E&M services for complications or high risk monitoring. Any inpatient E&M services that are more than 24 hours prior to delivery, any critical care, or any management of surgical problems. And the one I see practices not billing a lot of are any maternal mental health visits. Maternal mental health visits, you can bill three prenatal. To most insurance companies will cover three prenatal and two postpartum, as long as you have a documented EPDS screen. Um, a home pregnancy test does not count as a confirmation of pregnancy visit. You have to confirm pregnancy. I don't know the amnio infusion code off the top of my head. I would have to look that up. And so I will have to get back to you on that because I don't know. What can be billed for OB care inpatient outside of global for long labors, long inductions like multi-day? You can bill for the admission, you can bill for rounding, um, but anything 24 hours prior to delivery, when they're inpatient, you can bill for. And yes, vaginitis during pregnancy is included in global. ACOG says it's routine, and I don't like ACOG very well. Um, any other questions on global? Yes, time statements on discharge summaries do have an impact because the discharge visit is based on time. And um billing separately for additional follow-up blood pressure monitoring after discharge, that really depends on was why you're monitoring the blood pressure. Like, I understand why you're monitoring the blood pressure, but are they coming into the office for blood pressure monitoring? Is there a diagnosis of preeclampsia? Like, what is the diagnosis involved? I would chart it and let your billers figure out whether or not it's billed separately. And yes, if you're doing a confirmation of pregnancy visit, the physical exam and history have to wait for the prenatal one. If you admit a patient and they deliver 48 hours of labor, yes, you can bill a hospital day because it was not within 24 hours of delivery. So when do you not bill global? When do you bill separate prenatal, delivery, and postpartum services? The most common scenarios occur when more than one provider or practice performs maternity care during the global period. So they transfer into you from a different practice or a different group. Or their insurance changes during maternity. So they change from Aetna to Blue Cross Blue Shield, for example. Or if prenatal care is initiated late. And when prenatal care is initiated late really depends on the payer. If they've had no prenatal care prior to coming to your practice, typically the payer will still want you to bill globally. Um, if you labor sit and manage labor and then it ends in a C-section, right now you can not bill anything. unfortunately. Um, that potentially will change in January, but the new codes for 2027 do not have prices yet, and if they're not priced before CMS votes on the final rule, then they won't be approved for January of this year. They'll roll into next year. Is a 72-hour postpartum hospital stay reimbursed for blood pressure monitoring with a diagnosis of preeclampsia after a vaginal delivery? That depends on several factors. A hospital stay more than 24 hours for a vaginal delivery requires pre-authorization. If pre-authorization was obtained and the diagnosis in the pre-authorization was for blood pressure monitor or was for preeclampsia, probably, but it's going to depend on the payer. A lot of things depend on payer policy, especially or your contract, especially in a hospital. Can a home birth practice receive a global fee and not offer three ultrasounds and a separate entity bill for the ultrasounds? Yes. And this applies, there are some practices that don't do ultrasounds. They refer out to a different practice or radiology for an ultrasound. And this is just a chart that explains how the different visits are billed. So antepartum care only 1 to 3 visits, billed per visit. Antepartum care 4 to 6, you're billing with a global code. 7 or more, a separate global code. And now the commercial payers, the majority of them require that you bill a global code for postpartum care only instead of billing postpartum per visit. So the 2 midnight stay is that yes, all insurance companies will cover a stay for 2 midnights. Where 2 midnights came into play was hospitals were billing a 2 day facility fee for a patient that was admitted at 7 o'clock in the morning to yesterday, February 9th, and discharged at, you have to stay. The 24 hours was actually replaced by 2 midnights. So you have to, for a vaginal delivery, to bill for the hospital to bill the full facility fee, the patient has to be there over 2 midnights. Any more for so Medicaid 59430 for a Medicaid patient, most Medicaid plans require you to bill per visit. Commercial requires you to bill global 59430 for global postpartum care. Medicaid plans require you to bill per visit, the majority of them.
You've got one other one up there, Arden, about a home birth practice, global fee, and three
Yeah, I
different
talked
codes.
about that one.
Okay, sorry.
Nope, that's okay. Any other questions on billing before we move on to compliance? So if the coder's kicking it back saying it's global, did you bill global maternity care? Like, did you see the patient for the whole global period? If so, then you don't bill 59430 because that is only the global postpartum code if you did not see the patient for the whole global period. Any other questions? Otherwise, we're going to, in the interest of time, move to compliance. If a patient has a 3-day induction of labor and ends in a C-section, can you bill 2 hospital days? Yes. Okay. We're going to move on to compliance, and then if there are any other billing questions, I'll go back to them at the end. So compliance really ramped up with the use of AI. Imagine that. So in 2025, the National Healthcare Fraud Takedown resulted in 324 defendants charged in connection with over $14.6 billion in fraud. This was the largest fraud in US history. In addition to the 14.6 billion and the 324 defendants that were charged, there were an additional civil charges against 20 defendants for an additional 14.2 million and civil settlements with 106 defendants totaling 34.3 million. Now, why is this important? It's important because every single claim that is submitted under your MPI number, you are responsible for, even if it was not your error, even if it was your coder's error or your biller's error, the provider whose NPI number that is on the claim is ultimately responsible. So, what is fraud? Basically, it's those who deceive the healthcare system for their benefit, whether it's intentional or unintentional. The biggest instances of fraud that we see are improper documentation, both intentionally falsifying records to obtain higher reimbursement or in unintentionally coding something or charting something incorrectly. Intentionally falsified records are very, very difficult to detect. And that is what happens the most, where the medical record is altered to increase the level of service in order to obtain higher reimbursement. Um, there's been instances of fraud where the data service is changed or where the rendering or billing provider is changed in order to obtain higher reimbursement. And just as it's illegal for a provider to knowingly alter the medical record, it's also illegal for the biller to change the claim to increase reimbursement for the practice. So, how do you spot it? So, unintentional again is just simple mistakes or poor practice workflow. Intentional is made by a person with the knowledge that the deception could result in a benefit to himself or another person. Intentional also is reimbursement for services that are not medically necessary or weren't rendered. So, how do you prevent it? As a provider, you're responsible to only chart what occurred during the visit. If you don't chart it, it didn't happen. So, it could even be something that occurred and you didn't chart it. Again, don't chart it, didn't happen. You also should always sign and authenticate your own charts. If any other clinical staff enters notes in the medical record prior to you signing it, you should review those notes for accuracy. If you're using, I forgot to add this to my slide, but if you are using AI in your EMR to transcribe your notes into the medical record, you have to check it for accuracy. AI is not accurate 100% of the time. You should have quarterly chart or billing audits from your coder or from your biller where they're reviewing your charts and coming back to you with feedback of things that you can improve on. And then ask for quarterly reports from your biller or your billing service so that you know what's being billed under your MPI number. Upcoding is also a common source of fraud. Upcoding is when you assign a diagnosis code for a more severe condition than the reality of the patient's health, or when you document more time spent face to face with the patient to increase the level of E&M code. And upcoding can be unintentional due to lack of education or understanding. In fact, oftentimes upcoding is unintentional. And just as important is downcoding. Most people don't realize that downcoding is also fraud, but if you are intentionally charting less time than you spent because you feel bad or you don't want the patient to have as much patient responsibility, that's also fraud. So, how do you prevent upcoding? Implement coding practices that meet regulatory requirements. Train clinicians, billers, and coders on the most advanced coding procedures. Somebody needs to audit charts and codes to identify and correct errors. Ask for quarterly reports on the most frequently billed charges. And just so you're all aware, the OIG now keeps a list of codes that are ripe for upcoding, and payers are using AI to audit claims containing codes from that list. A really good example is, especially in midwifery, it's not upcoding to use a 99215 when you're coding on total time spent because you are spending that much time with the patient. But what we're seeing is the payers are keeping a list, they're using AI to keep the list of how many times a practice bills 99215 or how many times a provider in a practice bills 99215. And then they'll start asking for chart notes on every single one of those claims. And then they will send a letter. Typically, the first letter is slapping your hand, telling you to stop using it. Then the second letter is telling you that they are going to start downcoding all of your visits to a 99212 or 3 or a 99214. And it's up to your biller to appeal these decisions if your chart notes support the higher level of coding. Excessive billing, billing claims for multiple providers under one provider's NPI number. Not only is this excessive billing, it's also improper incident to billing. Billing claims for services that were not rendered and billing for patients that were not seen. All of this was happening in the fraud that was just the takedown of last year. So, how do you detect excessive billing? Insurance companies keep a roster for all the providers in a group. If somebody was billing 30 claims per day and now they're seeing 90 claims per day for that same provider, they're going to do an audit. They're going to audit charts. They're going to take money back. AI tracks how many claims were submitted, again, per provider, per practice location, per day. It also tracks the number of claims submitted per provider per E&M code per day. And then it's up to your billers to track the credentialing for each of your providers at each location. And yes, when billing for time, it includes chart review, outside record review, not just face-to-face time, as long as it was done within the same calendar day. So any total time spent today goes towards today's E&M visit. But if you reviewed charts yesterday or records review, outside records review yesterday, for a visit today, that total time, that does not count in your total time spent. Um, Sometimes we have a patient on one provider's schedule and something happens and they get switched to another at the last minute. If the new provider is writing the note and dropping the charge, how important is it that the patient get moved over under the rendering provider's name on the schedule? That depends on how your biller is billing. Are they billing off the schedule or are they billing off the charges that were dropped? And actually, they should be going in and looking at the notes to see who signed it, and that's how they should be billing. So your chart notes have to, in order to bill based on time, your chart notes have to say how much time was spent. I spent a total of 29 minutes face to face with Ginger or with the patient discussing XYZ, and another 15 minutes reviewing the chart for a total of, I don't remember what I said initially, but for a total of 44 minutes total time. Your notes have to be detailed when you are billing based on time. Now, some EMRs count the time for you, but your chart notes still have to say how much time you spent face to face. The other thing too that AI watches for is that your total face-to-face time is not the exact same amount of time for every single patient you see. I saw a practice get audited because their notes all said the exact same thing. Spent a total of 45 minutes face to face with the patient. And the payer's like, well, you can't spend exactly 45 minutes face to face with every patient. Was it 43 minutes? Was it 47 minutes? Was it 12 minutes? It cannot be the exact same for every patient. Incident to billing. Incident to billing is one of improper incident to billing is one of the biggest instances of fraud that we see, especially in doing auditing. So the fundamentals of incident to billing, first and foremost, it only applies in an office setting. It does not apply in a hospital or in a birth center or an ambulatory surgery center or any other institutional or facility. It only applies in an office setting. Both providers have to be credentialed with the payer that you are doing or your billing incident to. The physician or the supervising provider must be present in the office and readily available for questions. The patient must have a problem or a diagnosis that has been previously addressed by the physician. So basically, incident to billing allows an APP to provide a service that is an integral part of a plan of care established by the supervising physician, and it allows them to bill under the physician's NPI. Incident to billing was initially started to help family practice docs so that they could see more patients in a smaller amount of time. Incident to billing, improper incident to billing, or things that do not qualify as incident to, are submitting a claim under a CNM when a CPM rendered the care. A CPM cannot bill incident to a CNM. Submitting a claim under a physician when a CNM rendered the care and incident to rules were not met, primarily when the physician never saw the patient. Submitting claims under a credentialed provider when the rendering provider is not credentialed. Both providers have to be credentialed with the payer. So I don't have an exact example of an incident to claim, but I can tell you an example. Um, so proper incident to billing, a patient is seen by a physician, and the physician comes up with a plan of care in a maternity practice. The physician does the initial visit, sets the plan of care, and then the CNM sees the patient for all the other visits. Most practices who bill incident to this way, a CNM incident to a physician, do so because the CNM is paid at a lower rate than the physician. So by billing incident to the physician, they're receiving 100% of the fee schedule instead of 80, 85, 90%, or 75% in some states. Improper incident two is a CNM establishes care and a CPM renders all of the other care, and all claims are billed under the CNM's name. That's improper incident to billing because a CPM cannot bill incident to a CNM. And in most states, a CPM cannot be credentialed with the payers. Consequences of improper incident to billing: insurance takebacks, loss of payer contracts, loss of the license for the billing provider listed on the claim, loss of the license for the practice, fines, or jail. I can tell you, this has been several years ago. My gosh, probably 10 years ago by now. A birth center was submitting all claims under a CNM who never saw the patient to Medicaid. And the CNM never saw the patient. In fact, in some instances, the CNM wasn't even in the country when services were rendered. One patient reviewed her EOB and filed a complaint to Medicaid because the name on the EOB did not match who she saw. Medicaid came in and did a full audit. They called the OIG. The Office of the Inspector General came in, told the birth center they had 24 hours to pay a fine. It was almost $500,000. They could not pay that fine. The next day, the Department of Justice locked their doors. That was improper incident to billing. Um, is billing incident to a red flag for insurance companies in this day and age? Yes. United Healthcare pulls charts on almost every single maternity claim submitted, and they review the charts. Medicaid, it's a huge red flag for Medicaid because the majority of Medicaid plans do not allow incident to billing. Most Medicaid contracts state that services have to be billed under the rendering provider. The rendering provider is the person that completes the visit.
So Arden, again, Ginger here. What if the midwife doesn't know how the billing is happening?
You should ask. You should ask for reports of all claims billed in your name.
Who are they asking?
Start with your supervisor, your program director, your supervisor, go to your biller. And if you're not getting anywhere, depending on the size of if you're in a larger institution, you might have to go to finance.
So are we going to say that just a inquiry and a conversation is sufficient evidence, or do you think you need documentation of recorded billing?
Well, if it were me, I would ask for a report of all claims billed in my name because you're the person that's responsible for it. You're responsible for the claims that are submitted. Now, some things to keep in mind and some things that come up a lot are, well, first I'll answer Jenny's question because it kind of plays in. Can you bill under a supervising provider and not rendering if someone's still in orientation? If you are billing under a supervising provider simply because that person has not been credentialed yet, that's fraud. If you are billing under a supervising provider who is at every visit with the person who's still in orientation, that's fine because they're at the visit with the person in orientation. Now, there are also things that come into play like payer contracts. There are some states and some payers, like for example, Blue Cross Blue Shield of Georgia, there are some contracts out there that state that every claim has to be billed under the supervising physician, even if the supervising physician is not present when the service was rendered. Contract trumps. So if the contract states that, you bill according to the contract. There are some contracts that state that all claims are billed under the doctors and no claims are billed under any APPs. Again, contract trumps. If you're in the hospital, incident to rules don't apply. You are billing according to your hospital policy, your contracts, the bylaws, because there is no incident to billing in an institutional setting. Here's an example of where an owner of a practice actually turned themselves in. So, overbilling at a women's healthcare group padded private equity profits while costing patients. So the doctor of the company turned whistleblower, so turned himself in because he compiled a spreadsheet of examples of upcoding. He compared two sets of documents. One was the charts from the EMR showing the CNM as the rendering provider. The second was the EOB from the insurance company showing that the claims were billed under an MD. The charges included prenatal and well woman visits, ultrasounds, and IUD insertions. Claims were submitted to commercial, Medicaid, and Medicare. And it was an estimate of $150 million of claims that were billed incorrectly. Now, he turned himself in. They found it, they were guilty of upcoding, but was it upcoding or was it improper incident to billing or was it both? In my mind, it was improper incident to billing or probably both. But I don't make the rules, and the Office of the Inspector General said it was upcoding. So, what do you do if you suspect fraud? Again, ask for a report of all claims submitted in your name with your MPI number. Ask for a meeting with your biller or your billing service. Report any errors or issues to your supervisor or your compliance officer. And you can also make a direct report to the Office of the Inspector General. The OIG hotline accepts tips and complaints from all sources about potential fraud, waste, and abuse, and you do it all online at oig.hhs.gov/fraud. And when you're reporting, you have to have facts. You have to have examples of why you were reporting the suspected fraud. Okay, that was a whole lot of information. Do we have more questions?
If folks want to turn their cameras on and ask questions, that might be easier for Arden. We've got some time here.
So I guess I just wanted to clarify the incident to billing. First of all, it just seems weird that that's even a thing, that it's not just automatically fraud. But so I guess what I'm hearing is if you're providing services as part of a care plan under a supervising physician, and that physician is in the office at the time of the service and available for questions, then that's okay. That's proper.
Correct. As long as the physician establishes the care plan. So they need to see the patient for the first visit. They need to establish the plan of care, and then they need to be available in the office suite, so in the building for questions. And if at any time the care plan changes,
Mhm.
so if at any time you determine that there's a problem in addition to what was part of the initial care plan, the physician needs to see them again and establish a new plan of care.
Okay, so can I just give an example? So say a patient comes in for abnormal uterine bleeding, physician sees her, and an EMB is part of that care plan, then the CNM can do the EMB and bill it under the physician if the physician's in the office at the time.
As long as the physician is in the office and it's part of the care plan.
Okay. Okay. All right. Thank you.
I think a good example, Arden, that you shared, because this was really pushed by AAFP family docs, who still to this day have a position statement that they directly supervise APPs,
Hmm.
right? ACOG does not say that, but family medicine does say that. So if you can think of it that way, that could be helpful.
Yeah, and it was so again, it was initially started as a benefit. So AAFP went to CMS and petitioned for incident to billing so that they could manage APPs, see more patients in a day, and have everything billed in their name. And the benefit to a practice for incident to the primary benefit is money because most most contracts, most states, even states where it says that CNMs are to be reimbursed at 100% of the physician fee schedule. Blue Cross Blue Shield, for example, may have a contract that says that CNMs are reimbursed at 85%. So by billing incident to the physician, the practice is getting 15% higher reimbursement than billing under the CNM. So the primary motivation is money. The second motivation is WRVUs. Who are they allocated to? The billing provider or the rendering provider? And if your pay is not based on WRVUs, then it doesn't affect you as much as the physician whose pay is or bonuses may be based on them. Um, Global billing. Patient has already established prenatal care, but then calls clinic with vaginal bleeding. Can you order an ultrasound, but you bring the patient to the office for a problem visit to review the ultrasound, make a plan for follow-up? Can you bill separately? Um, yes, but that's not to say that the payer will pay it. They may include it in global. And then it's up to your biller to push it back. Any other questions? What code should we use to bill for hospital day 1 and 2 for long 72-hour induction? Um, I don't know off the top of my head. Unfortunately, I don't know every single code off the top of my head. I know a lot of them, but not all of them. Um,
Would it be the codes for the initial day hospital management and then the
yeah,
subsequent day
yeah.
hospital
So
management at
it's
like whatever level?
so the initial is the 99221 through 223, and then the rounding visits. So 231 through 233.
I have a question that I feel like is probably kind of silly, and I'm probably the only one who doesn't know this. Global fee, is that standard per state or per? I mean, is there anything standard about it, or does the insurance company decide?
No,
Or global
ACOG decided. So the global fee was determined, or the global reimbursement fee, or what's included in global?
oh, the reimbursement fee.
Oh, the
Like,
reimbursement fee, the payers, the states don't really decide. So CMS sets the physician fee schedule, which is the minimum amount of reimbursement. And that's the Medicare rate. And then the Medicare rate varies based on state and zip code. So different states receive higher reimbursement and different zip codes within a state. For example, in California, San Francisco receives a higher reimbursement than, say, Fresno because of the zip code or the locality. And then from there, the payers set their fee schedule, which is a percentage of the Medicare allowed amount. And every year for the last 6 years, I think, the Medicare physician fee schedule has decreased, which means the reimbursement rates for all provider types have decreased. Locums are billed under the provider they're covering for, and that is acceptable. There's a time period on how long a locum can be in a practice before they have to be credentialed. I think it's 7. I have to look it up. It's either 59 days or 79 days. But the locum is there to fulfill the duties of somebody else. So they are billed under the person that they are covering for, whether it's they're out for surgery, deployment, maternity leave, whatever the case may be. And then there's a modifier that goes on those claims to show that it was a locum. So you should bill for every day that you are seeing a patient in the hospital. If it were me, I would drop charges for every single day that I see a patient in the hospital. When I admit them, when I'm rounding after delivery, when I discharge them. It's up to your biller to determine which of those days are included in the global or in the delivery charge, not you. Postpartum patients that don't come in until 7 weeks postpartum. Most practices, if a patient comes in 7 weeks postpartum because of scheduling and they couldn't get there for until 7 weeks, most practices consider that part of global. They don't bill the patient for that or submit an additional bill for that. Any other questions? With Medicaid, doesn't matter how many weeks postpartum. It depends on the state and if it's straight Medicaid or one of the MCOs. And it also depends on if you're billing globally or if you're billing that state per visit. Every state for Medicaid has different rules, and then the MCOs within each state have different rules. So Medicaid has a provider billing guide. I read it for every state that I bill in or have consulted in, and then you have to go read the separate billing guides for the MCOs. And we have detailed online notebooks for all of our practices because it's hard to keep it all in the top of your head. Um, Mental health visits are billed on time, and you have to document an EPDS screen. Shannon, I don't know Illinois Medicaid rules off the top of my head. I would have to look them up. G codes are only for Medicare. Other Medicare billing specific things, the biggest one is you cannot bill a preventive visit to Medicare, like 99, you can't bill the preventive medicine codes, 993, 85, 86, 9596, etc.
Hey Arden, I think it's fun what Jenny wrote about how you got into this. So I'm gonna do an infomercial. Um, we started a podcast called The Possibilist Midwives. Denise, who's on tonight, one of our colleagues, and I co-host it. The third podcast, which was just released this weekend, features Arden talking about why she got into billing and is offering even more diverse information than what you're hearing tonight. This was really specific to the ACNM presentation in Palm Springs, but I think you'll even learn more if you tune into that podcast and see why she likes all of this so much.
And I'll give you the abbreviated answer now. I kind of fell into it. I had just finished radiation for breast cancer. My husband told me not to work at the job I was at, get a part-time job. So I did, doing verification of benefits for a billing service for midwives. And I can't work part-time. So within 6 months, I was a biller and full-time, and then the director of operations for like almost 11 years. Then I quit to work part-time again, and again can't work part-time. Found Ginger and Grow Midwives, and here I am. And I just love, I started out loving advocating for the parents, and then I developed close relationships with a lot of my clients, a lot of midwives, and now I advocate for both sides.
Arden, Arden, can you share with them if there's value in maybe looking at the ACOG coding resources they have, or using the WRVU calculator that's free online? Are there resources you might be able to point them to? A couple people have emailed me asking for handouts, which we do not have, but maybe you could give some ideas that, like the top, I think WIPSA has the top codes for women's health, which is part of ACOG.
Yes, WIPSA does have the top codes for women's health. Here, I'm going to put some links in the chat. So, AAPC, which is the American Association of Professional Coders, they have the standard in WRVU calculators. Um, I just dropped the link for that.
I just put
And then
WIPSA in, Arden.
what?
I put WIPSA in.
Okay, perfect. And then Ginger dropped the link for WIPSA. And then I touched on this briefly in the presentation, but I want to touch on it a little bit more. The potentially the codes are all changing January 1st of 2027, and the global maternity codes are going away. If I were a healthcare provider right now, especially women's maternity, women's healthcare, I would start documenting in your charts every single thing that you did and the total time you spent doing it. Because when the codes change in January, every single one of your prenatal visits will become an E&M code, and it will be based on total time spent in that visit. And things will become billable, like how much time you spend labor sitting, how complex was the labor, were you just managing an IOL and you were not, it wasn't complex, you were just there? Or were you managing a more complex labor, more problems in during that period? Um, Document if you were you should already be doing this because it's billable. Documenting if you're a first assist on a C-section, that's billable. So you should be documenting that. But there will be additional codes to learn and additional things to document when those changes take place. Um, and we'll just have to do another webinar when that happens. Yes, if these changes take place on January 1st of 27, global OB care will be gone. And it will be replaced with per visit billing. And the whole premise behind this is that in ACOG's belief, the it will provide better reimbursement because you will be reimbursed for the time that you actually spend managing a patient's care. We just don't know what those reimbursement rates will be or what the WRVUs are. They, AMA and ACOG and all the other acronyms have to meet with CMS and assign value to each of the codes. And I was on the committee for the codes, so there was a voice at the table.
I think that's really important to say, Arden, because at least in the first round, you and I were invited by ACNM through the ANA, believe it or not, to have some voice because there was a WHNP formally on that panel. Actually, Sue is a friend of mine, but she had no idea what the midwives were doing in patient care. So she could reflect on ambulatory services, but not on inpatient services. And I think she really helped midwives be at the table on that one.
Hmm.
And I think they listened, especially in some of the definitions that we noticed that they hadn't thought about.
Especially when they realized that the consultant that the AMA had hired to develop the CPT codes for maternity care had never ever coded or billed maternity care.
Yeah, yeah, yeah. It's interesting. Stay tuned, I guess, huh?
Yeah, hopefully.
Here's a plug. Here's a plug to join ACNM and join the educational ACOG affiliate. If you really want to stay on top of this stuff, um, as it comes out, instead of waiting on social media or your friend to tell you something erroneous, that I would really encourage you to do that because it does impact your ability to understand. Yeah, are they pushing for quality of care against the WRVUs? Is one of the things I actually thought about.
Hmm. And I agree. Global OB is grossly underpaid.
Yeah, we now have doulas making more than physicians and midwives for a panel of care, delivery, and postpartum. It's mind blowing. So I think your point, Arden, maybe we wrap it up here that there's only so much of the pie,
Hmm.
right?
There is. There is only so much of the pie, and what people don't realize is the f- the physician fee schedule, Medicare's physician fee schedule is based off of a budget. It's based off Medicare's budget. And then so much of that is allocated to different associations. So ACOG gets so much of the budget for the maternity codes, cardio, ortho, AAFP, pediatrics, etc. The universal codes, like the E&M codes, those are all AMA. AMA determines the value of those. But there's a lot of behind the scenes motions that we normally don't see. A lot of negotiations. These codes almost didn't get voted in. They were kicked off the first round of voting because AMA and ACOG couldn't agree on something. They were fighting. And so it almost didn't happen at all. And then it was brought back in at the last minute. So, what value they will assign, I'm really interested to see, because there's only so much budget to allocate towards them.
Yeah. Well, I think we should all really, really thank Arden for dedicating her career to our profession and to the families that you all care for, because the the impact of the work you do is profoundly improving the health of communities. And so regardless of the setting you're in, it's just so complicated. I learn something from her every time I listen. This webinar is recorded, as many of you know when you came in. We'll put it on the YouTube channel. um, and Arden, I don't know how you want to wrap it up, but we really do thank you.
You're welcome. And thank all of you for everything that you do, because I learn so much every time I talk to you as well. And a lot of input in this presentation came from those of you who are rendering the care, providing the services, and who are willing to talk to me and give me more info. So thank you.
Good night, everyone. I'll stop the recording, Arden.